Dr. Pellegrini, for your presentation. As a former psychiatry resident and fellow here at the train here at the UW, it's an honor to come speak with you today about this quality improvement initiative that I've been involved in. I know many of you in this room, and some of you are new faces, but in case any of you that are wondering, yes, I am pregnant. I am 36 and a half weeks pregnant, to be exact, with my third child. So I'm excited to be talking to you today. Try to keep this presentation relatively brief, not only in the interest of time, but just in case I go into labor. So hopefully that won't happen. But without further ado, I'll just go ahead and start. I'm here to talk about the Depression Path Project, which is Population to Health. Get that off the screen. And Population Approach to Health. And before I start launching into that, I want to talk a little bit about my journey and how I ended up getting involved in quality improvement work, and spend the rest of the time talking a little more about the details of the project itself, how it evolved, and what we've been able to accomplish so far. So just a little bit about myself for those that you don't know me. I completed my residency training here and fellowship as well. Started on faculty in 2012. And since then, I've been working in collaborative care as a consulting psychiatrist to our primary care clinics in our UW system. The majority of my time is spent in the BHIP program that Dr. Pellegrini mentioned. That's the Behavioral Health Integration Program. It's our UW version of collaborative care here, where we have embedded mental health teams in our primary care clinics. And I've been doing that for a number of years. And then in 2016, I started taking on more of an administrative role and became the associate medical director of the BHIP teams, so the Behavioral Health Integration Program. And my hope was to continue to support those ever-growing number of BHIP teams that we have expanding in our network, and help continue to improve the care that was being delivered in those collaborative care sites. So through my clinical work, I started to recognize more opportunities to improve our healthcare system in terms of the way we treat mental health disorders, and became more and more interested in trying to find ways not only to standardize the way we deliver our care, but hopefully improve patient outcomes by improving our system of delivering this care. So around that same time that I was starting to think more about healthcare systems and the delivery of care, I saw this email that came across my inbox from Dr. Pellegrini that was inviting clinicians to participate in something called the Clinic Practice Innovator Group. And I didn't know much about it at that time, and I spoke with Jürgen and asked him what he thought, and he agreed that it probably sounded like a good fit for me and what I was interested in. So I went ahead and signed up to participate in the program and learn more about it. And from there, I became part of that inaugural group of CPIs, like Dr. Pellegrini was mentioning. And looking back at that info from those initial kickoff meetings that we had last year, it did seem like there was around 336 or so clinical practice innovators, which are clinicians from all different departments across the UW medicine, 27 of which I believe were listed from psychiatry, so maybe some of you in this room were also CPIs in that group. But really, Ryan Kimmel and I were joined forces together and joined the group and put forth some proposals about depression care and standardizing depression care that kind of became a little bit of the outline for this Depression Path project that I'll talk about today. And I was really pleased to see when I went to some of those early meetings that depression was highlighted actually as an important focus area for not only standardization, but really a way to integrate primary care and specialty care as well. So that's a little bit about the start of my journey on this quality improvement path that I started on. And throughout this talk today, I'll talk more about my experience within that. But aside from talking about my journey, I hope to leave with you some additional thoughts. And these are sort of my objectives for today's talk. One is why focus on healthcare transformation, and hopefully we already got a lot of that information and great background from Dr. Pellegrini's talk already, and also give you a little my own perspective of how I came to it and why I've now decided to dedicate a lot of my time to healthcare transformation. I hope to also spend through the talk today have you understand a little bit about how the UW is addressing depression care, and then what is the Depression Path project that we're working on, and give you some more details about that. And then what I have learned, as well as we from the Depression Path team, what we've learned about this project, as well as the Department of Psychiatry, what we've learned about quality improvement. So to give you some background to the work that I've been doing and set really the context of how I became involved in both the CPI program as well as the Depression Path projects, I want to spend just a little time reviewing how and where it all began. So that really starts in 2014 with the Affordable Care Act when it went into effect. And that established the rules for accountable care organizations. And in 2015, the UW became an accountable care organization and established its first contract with the Boeing company. And that's important, which I'll talk about a bit later, but the Boeing contract had specific outcome measures for depression that were part of that contract, which will become important for our Depression Path project. Also in 2015, UW received this large grant called the Transforming Clinical Practice Initiative Award that was awarded by the Centers of Medicare and Medicaid Services. And it was really designed to help clinicians achieve large-scale health transformations and improve quality of care, increase patients' access to information, and spend dollars more wisely. And some of those initial efforts were really prioritizing the coordinating of care for patients with chronic conditions and sharing data across practices. So in 2016, as Dr. Pellegrini mentioned, and under his leadership alongside Dr. David Flum, the CPI Innovator Group was launched as part of that grant. And really, as we already heard from Dr. Pellegrini, the focus is really on developing care transformation leaders and teachers at UW Medicine and helping clinicians like myself participate in care transformation projects, as well as having opportunities to participate in learning workshops. And so that's been a great opportunity for me. And then later on in 2016, closer to the fall, we started looking at creating a centralized depression care management team, which we later then called Depression Path. It was really more born out of the Boeing contract, as I mentioned earlier, that we developed as a part of becoming an ACO. And that Boeing contract really had that specific measures around depression targets. And we realized we weren't meeting those targets as an organization. So that really, that's where the concept of the Depression Path team came about, to really try to align and make sure that we were getting closer to meeting some of those contract goals and providing some centralized management to that. So that's a little bit of background from being an ACA to then how Clinic Practice Innovator Group came, and then the Depression Path team. Now, looking more at the UW Medicine approach to doing depression care improvement, this is more of an overview of that approach, and it's somewhat of a simplified schematic, and it really outlines the various different efforts that are being put forth to help improve depression care in our UW Medicine system, with each of these boxes really representing a different step in that process. So while these steps are listed here in a simplified visual for the sake of representing it on the slide, you should hopefully know that each of these steps is very complex and involve different work groups to address them. So a lot of effort is and was put in to really figure out how to do each of these steps. And I think for me represents the reality of doing important yet complicated health transformation work. So while each of these steps is really too complex to go over in depth, I'm just going to touch on them briefly to highlight how each of these steps is an important part of our UW approach in improving quality of depression care, with the first being empanelment. So that's really to answer the question of who are the patients that we're trying to serve. And empanelment really is the process of assigning patients to individual clinics. So for instance, assigning them to adult medicine clinic or to our UW Medicine clinics, primary care clinics, and for us to be able to clearly account for all those patients that we're serving so we have a better idea of who our patients are. And out of that process, out of that empanelment process, we came up and we were able to actually see that we're caring for nearly 240,000 patients in our primary care clinics. So that whole big circle represents those 240,000 patients, with this kind of blue pie piece representing the people that we've found out carry a diagnosis of depression. So that chunk of patients, nearly 40,000 patients carry a diagnosis of depression. So of those patients, we kind of assume, so what's happening with those patients? Well, we can kind of estimate that some of them are severe enough to really need inpatient or residential treatment. Some of them get a referral, and they get referred to see an outpatient clinic within our UW system. And some of them probably get referred out and see mental health somewhere else. And then there's the BHIP team, what I mentioned before, our collaborative care team it's embedded in our primary care clinics. And some of those patients are getting seen there in the primary care setting. But that leaves an estimated 85% still being managed by the primary care teams themselves and not getting really specialty care. So going back to this schematic, once we know who our patients are through the process of empanelment, we really want to take those patients and say, out of those UW patients, which of those patients have depression in the first place? So therefore, we need to really do good depression screening. And again, this is taken on by a different group, the population health group. So we won't go into detail there, but we need to screen our patients and make sure we have appropriate ways to find out who has depression. So the next piece is really going to the depression care pathway. So this is, once we identify who our patients are and screen them for depression, how do we ensure that the patients are receiving appropriate interventions and standards of care around depression? And that's where the depression care pathway comes in. So now this is a visual. No one's going to obviously be able to see anything on that screen there, but it's a flow sheet which represents what the depression care pathway is. And the depression care pathway is a clinical pathway. So I just want to call out the fact that depression care pathway sounds a lot like depression path, which is our project, and they're very confusing, but there are two different things. The depression care pathway is a clinical pathway. It's focused on developing clinical guidelines for primary care providers to follow when they have a patient that comes into the clinic diagnosed with depression. It's similar to different pathways that are being developed for diabetes, hypertension, and low back pain. So it's a clinical guideline. It's basically 4 PCPs to follow an algorithm, like this flow sheet that you see here, that get identified with depression, and then they utilize smart sets and Epic to be able to put the patient literally on a pathway and then have them outline a standard of care for those patients. The pathway includes recommendations on timeframes of when the patient should come back for follow-up, guidelines around treatment and interventions, as well as recommendations on when to obtain a follow-up PHQ-9. So I also want to just point out that the pathway is another CPI project and is highlighted here in the newsletter from the CMO's office, Dr. Pellegrini's office. So that's another healthcare transformation project that's being worked on. So now that we have these care pathways, another piece of the approach to depression care is having integration of specialty care into primary care, allowing for team-based care and for patients to be able to be referred when their needs exceed the scope of primary care setting. So integrated based care is really to answer the question of how do we integrate specialty care? And actually this is something that we've already been doing for years, and as we do well in BHIP. And we've been successful at integrating mental health care into our primary care setting with our BHIP programs. And that finally brings us to why I'm here to talk today is really the centralized care monitoring piece, this depression path program that we're a part of. And this is that accountability piece that we were talking about, to be able to really help answer the question, how do we ensure that our patients are getting better and really demonstrate that they're getting better? So that's the Depression Path Project. So what is and who is the Depression Path Project? So right now it's really Mark Avery and myself, those two bubble heads in the middle there, and Jason Shu, our amazing project manager, who's sitting over there as well. And the three of us are really kind of comprised of the Depression Path Project right now. And together we look at the data. So we have a population dashboard that gathers the data that's an aggregate from all our UW medicine patients, and that allows us, looking at the data, looking at clinical outcomes such as PHQ-9 scores, who's received them, who has elevated scores, who did or did not receive follow-up PHQ-9s, and did they reach remission. So our Depression Path team really does these centralized reviews of these patients, and we engage with all these different entities that you see here, neighborhood clinics, Hall Health, UW-MC, Harborview. Valley's not participating at this time, but we hope to engage with them as we kind of find ways to eventually merge our data. So together, we're all working on looking at these patient populations, but it's really focused on the Boeing, PEB, and Premier ACN contracts, so the accountable care networks that we work with. So some of you may be wondering, where do you get this data from and how do you get this information? So again, you're not going to see the level of detail here on this slide, but this is just a snapshot of what we see from our population dashboard. It's a complicated looking dashboard, but it's actually very neat, very slick, very cool. So we can use that, and it's really a population information. So it takes information from polls from all our EMRs, Epic, Orca, Mindscape, etc., and then pulls all that information, and we can use that information. It comes up and it has all this data where you can slice and dice and filter, which is really cool. And so for instance, we take a look at, and we filter down to looking at just the ACM patients, and you can't see it on the left, it's too small, but you can filter down to just Boeing if you want to see Boeing, or Premier, or PEB, and then you can look, filter down to just looking at the patients that got diagnosed with depression, the ones that had high PHQ-9s, and then try to see whether or not they got follow-up PHQ-9s and whether or not they were in remission. So this is just a visual of that kind of data that we're looking at and using. So our overall goals in the project are really, again, focused for now on the ACM population, but we're really hoping to improve depression tracking and documentation, as well as improve identification of those patients that are not improving, and then hopefully improve their outcomes in regards to their depression care. Our overall goal, though, is eventually to expand, not just to focus on ACM, but to really expand that to whole UW medicine-wide, because our goal is obviously to improve care for all our patients. So the next slide here that I'm going to talk is just a visual. It's kind of a concept slide, because some of you are maybe thinking, okay, I've heard depression care pathway and depression path, and it's all confusing, and I don't know what it means. So this is hopefully a visual to kind of try to bring all of that together in what we've presented so far. So this is that population approach to depression. And so here's a population that we're working with. And by that empanelment process, we now know, okay, there's a number of people that we take care of here at the UW Medicine. And through that screening process, we know, okay, these are the number of patients that are depressed. So imagine that's our population of depressed patients that we're seeing, and we want to make sure that they're getting appropriate care. So then we apply the depression care pathway for these patients and really want them to be on a pathway so that they're getting standardized care. Now that pathway is also a pilot, and so it's currently being piloted in these 7 clinics, and that is a way for patients to get on that pathway to get standardized care, clinical guidelines, and treatment guidelines. But as we all know, sometimes patients fall through the cracks. Sometimes they don't stay on the pathway, they fall off, we either lose them to follow-up, or perhaps they're not really within the scope of the pathway. Maybe their needs exceed what the pathway is recommending. So that's where our team comes in. So we capture those patients. Right now, again, we're just focusing on ACM patients, so it's a small slice of that pie, but we're really looking at those patients that for some reason or the other are not really following the pathway. So we can imagine if they're on the pathway and they're following those guidelines and they're getting follow-up, they're getting those patient guides, we're really trying to reach remission and reach target. But for some reason, if they're not, then we're capturing them on the other end as the depression path team, as that centralized monitoring, to pick up on those and still try to intervene and make sure that they're going to reach target. So again, if the depression pathway is working as well and perfectly, then hopefully we won't get any patients. But as we all know, that there's probably still some role for centralized monitoring, since there are going to be patients that fall through. So the depression care pathway and the depression path team, even though they sound very similar, they're different programs and they have different approaches and different spread, but the aim is the same. We're really both trying to improve depression outcomes for our patients. So to go into a little more detail of what I do as a part of this depression path project is to really look at some of the data and the things that I do day to day. So really I take, again, those patients that are all UW Medicine patients. I'm just gonna walk you through what I do on a regular basis, and then use that population tool that I was talking about and showed you a visual of to filter just to those ACM patients, Boeing, PEV, and Primera. And for the sake of this example, I'm just gonna use Boeing, since that's the first contract that we looked at and where we started off with. So if we're just looking at Boeing patients, the question is, how many of those patients have a diagnosis of depression that was diagnosed within the last 2 years? So we're looking at just those newly diagnosed patients. And that really turned out to be 87 Boeing patients, at least from this April data that we're looking at. And then out of those 87 patients, how many of those patients had an initial high PHQ-9 at the time of diagnosis, defined as, PHQ-9 given between plus or minus 30 days of that diagnosis? So really only 53 or 61% of those patients that got the diagnosis actually got a PHQ-9 at the time of diagnosis. So then out of those patients that got a PHQ-9, which of those are elevated? So that's where we're really trying to target, is those patients that have elevated PHQ-9, so that moderate to more severe depression. And we're trying to focus on getting those patients better and having improved outcomes. So those are our target population. And really that number is only 29. So only 33% of those first 87 patients are the ones that we're really honing in on and trying to see how are those patients doing. So basically that's where I take those patients, I filter all that down from the dashboard, take those 29 patients, and that's the depression path team, and I personally go in and look at each one of those charts and see what's happening with that patient. Where are they? Did they come back for follow-up? Did they get another PHQ-9? What interventions are being applied to that patient? And again, just for the Boeing contract example, we're looking at our goal is obviously to ensure that patients are getting better, reaching remission, and per the contract, the target is really getting the PHQ-9 to be less than 5 or 50% improved. So let's look and see, out of those 29 patients, how many of those patients got better? Well, first of all, we have to see how many of those patients got a follow-up PHQ-9 at the 6-month time frame, which is what the contract requires. And really, only 8 of those patients got a follow-up PHQ-9, so less than 30%. So that was a key lesson that we learned, that if you don't measure, how do we know that they're getting better at all? And so we missed an opportunity here with 21 patients, or almost 77% patients not getting a follow-up PHQ-9. So we have no idea how they're doing. We don't know if they're better, they're worse, or what. So really, while we want to focus on outcomes and getting people to remission, we quickly realized the first thing we need to do is focus on getting those follow-up PHQ-9s in the first place. So we started off by focusing on those patients that were approaching their 6-month deadline, trying to capture those patients to make sure they got their 6-month PHQ-9. But as we were able to do more with this project and as we moved through the phases of these projects, we were able to identify patients earlier on in their time course. So for instance, maybe month 2 after they got diagnosed rather than waiting till month 6. So by getting them earlier on in their time course, that we were able to alert the clinics and teams so they might better engage with the patient and maybe have more time to intervene to hopefully help have the chance that they would reach remission. So this is just a table showing some of the outcomes that we've seen so far. And I just want to note that we are a program that just started and just got started and launched in the fall. And again, this is just data from Boeing. So the numbers are super small and that it looks like we haven't done much, but it really is, I think, focused on a very small population right now. And we are adding PEV and Primera, which have larger numbers of patients involved in those. But really the way to look at this table is the blue, so 6 months prior to starting. So that's pre-depression path, so the central monitoring system, and the 3 months after we started. So prior to, in the blue here, really only 1 out of the 10 eligible patients to get a 6-month PHQ was getting a PHQ. So we were only getting 10% of those, as opposed to after we started our depression path project, we increased that number to 50%. So we got 3 out of the 6 eligible patients that could get a PHQ-9. And I just want to mention that the 3 that didn't get a PHQ-9, 2 weren't for lack of trying, because 2 we were contacting over and over again and they just never responded. So there are some patient factors involved as well as in terms of getting that follow-up PHQ-9. Also, in terms of improvement in remission, 5-point improvement, 50% improvement or remission. Prior to us starting, there was only really 1 person that got a 5-point improvement, as opposed to we had better numbers looking after we did central monitoring. We were able to get patients a better improvement, with more patients reaching 5-point improvement and another patient also reaching 50% improvement. And looking ahead, this data is only from April, but looking ahead in May and June, we have some more success in getting patients to remission as well. So looking at this visual is kind of this showing this scale and spread of our project. And so really in November was when we started, and we really kept it to a very narrow scope. Really starting with those Boeing designated patients, designated again meaning just the Boeing patients selected UW as their ACN. And so we started just looking at 1 clinic just to really test the question of whether or not we could utilize that population data to identify ACN patients that have elevated PHQ-9s. And then we moved to December, January, February, expanding that scope, expanding to all of neighborhood clinics, and then adding Northwest Hospital and Harborview. And then finally in February, adding all the UW Medicine entities like Hull Health, UW MCs, SCCA. And then March and April have really been spent trying to add and test the question of whether or not we can add and apply what we've learned to the other accountable care networks like PEV and Primera. So these are some of those sites that we've been working with. Again, we mentioned neighborhood clinics, Northwest, Hull Health, Harborview, Women's Clinic, General Internal Medicine Clinic, and the UW. And this highlights also the other aspect of our job in Depression Path and the work that I've been doing. I also wanted to call out Jason Chu again for his invaluable assistance to coordinate with these entities. And there's a really big communication aspect to this job, which is there's that chart reviewing and looking at patients at the individual patient level, but then there's also engagement of the clinics and the people on the ground doing this work. So if you remember that centralized picture with the 2 little bubble heads, it's really us outreaching to each of those clinics and saying, hey, you have a patient here that needs to be intervened upon. But each of those entities needs a communication plan or a workflow plan to be able to work, and they are the ones outreaching those patients. So that's a lot of also this job is doing a lot of communication and engagement with people on the ground doing this work. So here are some of the key lessons we've learned so far and the things that we're thinking about in terms of next steps. So far we've already identified a number of quality improvement and care issues, and we continue to identify them. For example, there's some system-based issues that we ran across already. So some of you may know that the PHQ-2 is used as a screening tool to screen for depression, and some of those PHQ-2s were erroneously getting reported out as PHQ-9 in our EPIC system. So that was a problem. So we went back and fixed that quickly. And then also, once we have a patient that's diagnosed with depression, they need a follow-up PHQ-9, but unfortunately sometimes they were being given PHQ-2s instead. So that's an issue that we're still working on as well. We also identified some process-based issues, just more like around standardizing our communication flow around with different entities, and also trying to find standard follow-up plans for depressed patients. And that's where also an opportunity for us to coordinate more with the depression care pathway, which would be very valuable. One thing we've heard feedback from, especially from clinics, is depression care pathway and the path, it sounds very familiar. It's confusing for us as clinicians and staff to really keep track of all these initiatives that are coming at us. And as a clinic level, people are asked to do a lot of healthcare transformation, a lot of different initiatives. So as much as we can, the feedback that we've gotten is to single message our objectives and what we're trying to ask people to do would be better, so that clinicians don't have to carry so much in their head about what am I supposed to be doing for this or that. So working more with the depression care pathway is definitely a goal of ours. Another thing that we really have been looking to do is also leveraging informatics and technology to assist with care management. So identifying a registry tool that everyone can use to track these patients, using eCare, which is our patient portal, to be able to obtain PHQ-9s, which would make it hopefully a lot easier for people to give us information about how they're doing and report back those PHQ-9s. Also building IT alerts into Epic to remind PCPs of certain tasks or other staff members to get PHQ-9s or other things. And we're also looking to, like we said, expand to other ACN contracts, which we're doing now, and then also eventually expand to not just focusing on ACN, but really expanding to include all of our UW medicine patients. So that is the end of my talk. I want to thank everyone, Mark Avery especially, for his partnership in this program, and mentorship, Dr. Jürgen Unitzer for his support and encouragement to participate in these quality improvement programs, Dr. Carlos Pellegrini and David Flung for your leadership around the CPI program and healthcare transformation, and Ben Chowdhury and Jason Chu for their participation and assistance in getting these programs launched. So I have open for questions.
Great presentation, Denise.
Thank you.
For the Boeing contract, so you said it was roughly 240,000 patients, roughly 15–16% have depression according to the medical record, right?
Yeah.
37,000 out of 20.
Yeah, so that's 240,000 of
Right.
all UW medicine patients. Yeah.
So if you just look at the Boeing contract, what was the denominator on that?
So it depends. We have different, the numbers are smaller for Boeing compared to PEB and Primera. Like for roughly, I think there was something like 3,000. Yeah.
So how many would you expect to be depressed using the same, it'd be 16%, 17% using the same kind of?
Yeah, I mean, that was an example from April's slide. So that was like 20, that was like 33% have just a small number. So we were talking about actual numbers too when we're talking to these clinics. They're asking us like, how many numbers of patients are we expecting to be able to be having to track? For a lot of these, it depends, because it depends on where they're going to. So for Boeing patients, a lot of them are showing up in our neighborhood clinic settings. But for instance, Hall Health has like 2 patients, adult medicine has 2 patients. So it kind of depends where they're going. But overall, it's a small number. It's like in April's data, 29 patients we're tracking. But PEB and Primera are bigger. Yes.
So it's, from what I understand, is it's like value is like you get reimbursed based on the value, but you're having trouble getting the data. I was curious how that fits in terms of reimbursement.
Yeah, I think that was the kind of impetus to doing some of the central monitoring, because we were not meeting targets for the Boeing contract specifically, and so we were losing out on some of that incentive pay because we weren't meeting the depression targets. And the depression targets vary from year to year, depending on it. And I think the goal is, we need to get so many percentage of patients to reach remission. And again, we're tracking that and hopefully using that as feedback too, to be able to kind of say, well, PHQ-9 of less than 5 is a pretty lofty goal, as we all know. So then you also tried to amend that to have 50% improvement as also another target. So it is true that they are linked to, reimbursement and payment, and that's partly what our group is focused on, and why we're focused on ACN right now, is to try to help align more and make sure we're meeting those targets and trying to get to that point.
I just wanted to add to that the ACO contracts are a little bit more complex. The way we currently get paid by Boeing, in the case of Boeing, is that we get paid fee for service. So in that sense, it's no different than anything else. When we provide the service, they gave us. But we have a contract and we have an agreement with Boeing that we are going to not exceed a certain amount of money that we calculated was representative of 2014, when was the time that the contract was being done, right? And so every bit of money that is paid to the system, somewhere in the Blue Cross in Illinois, they report back to Boeing saying, we pay this for your patients, we pay this for your patients. At the end of the year, Boeing looks at that and says, well, this was the contract. You could not exceed X number. You exceeded the number. If we exceed the number, we pay back half, and they put half. If we lower the number, then we get to get a benefit, and then is when the quality marks start coming up. And in those quality marks, they'll say, oh, you get 30% if we have 7 measures, one of which is depression. And as was correctly pointed out, that line moves every single year. At the beginning is simply, have you measured depression? How many patients had a PHQ-9? And that was the simple thing. And then you start saying how many of the patients who had a PHQ-9 who was less than X got better. And that is the next goal. And as you move that line in the depression environment in particular, but also on the pain and spine, they want to know how many patients who have been absent for 10 days because of illness, year such and such, are now absent this year. Did we correct the absenteeism of these patients? And how many patients that were present and went to work were unable to work, took some time off, needed somebody behind them, because as they are depressed, they are not really concentrating on their job and putting the energy and so forth. It's what they call presenteeism. The person is there, but they wish the person was not there. And so they are working on moving that target along. But what I wanted to remark of what you heard is this is what high reliability organizations do. Between Mark and everybody, Jason and everybody, you're looking at what are the defects on our system that maybe never surfaced, maybe never were seen to us before. So what are those defects that we have to, when do we call a PHQ-2 PHQ-9, for example? And that doesn't happen unless you are examining the system. And what lesson do you learn and how do you correct that? And when you make that part of the culture of an organization, like it's becoming now on your case, then you start moving the needle, because it's not, now you're not so much worried about maybe that little detail, but you're now worried about how many patients do we really get better when we measure them again and so forth. So I really congratulate you all, because I think this is a great example of what can be achieved when you get enthusiastic people that have fire in the belly. Well, they have more than fire. you have something on the belly that makes it, right? That makes it work, and how you move the needle. So I think the cynic would look at this and say, oh my God, after 3 months or 4 months, now what are you looking at? 4 patients, 6 patients, 7 patients? You're looking at the system. You're looking at the population management of a subset of the population. And you're looking at how do you grease this system to work in an almost perfect way. And every time you find an imperfection, how do you fix that imperfection? So you are concentrated on the failures to make the failures give you the next product that you have. So thank you so much for doing that. This is a wonderful presentation from my perspective.
Thank you.